Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. In this episode, I'd like to chat with you about bleeding for women on hormone therapy. Now, you can have predictable bleeding or, in many cases, unpredictable bleeding. So let's talk a little bit about what bleeding is even about. Well, if we go back to the menstrual cycle, everybody knows that a woman will have predictable bleeding every month, and that's called the menstrual period. And that happens in a healthy, reproductive aged, ovulating woman. So, just as a quick recap, when a female has a menstrual cycle, the first 2 weeks, if we say it's a classic 28-day cycle, the first 2 weeks are called, from the uterine lining perspective, the proliferative phase. Only estrogen is being produced, and it grows the uterine lining, or we use the word proliferates. It grows the uterine lining. Then ovulation occurs, and progesterone is added into the mix. So now you have both estradiol, the form of estrogen made by the ovary, along with progesterone being produced. Now, we call this phase the secretory phase. The progesterone downregulates the estrogen receptors and stops the growth or proliferation of the uterine lining. And then the uterine lining, it kind of like flourishes, it blossoms, it becomes more glandular and secretory in terms of making mucus, and it is readied for a pregnancy, or if a pregnancy doesn't happen, the shedding, which is called the menstrual period. And what happens just prior to the menstrual period is the production of both estradiol and progesterone plummets. The uterine lining becomes unsupported, unstable, and literally comes out in an organized fashion. And it's then readied for a new cycle, a new chance for pregnancy to occur. So, in menopause, and I'm not going to talk about perimenopause here, because women are still making their own hormones. They may or may not cycle on their own sometimes, or even all the time. So we're talking about menopause. This would be postmenopause, after the ovaries have ceased to produce any or very tiny bits of progesterone and estradiol. So they're not going to make hardly a thing. Their ovaries are done, okay? So in that group, the hormones that are given are the hormones that there is in the body. So if you give estradiol, and we're going to say estradiol because very few people, I hope, are using conjugated equine estrogens. That's under the brand name Premarin that was used in the Women's Health Initiative. So let's talk about using estradiol. That's what is preferred now by a long shot. So you give estradiol. That is going to do what it does. It causes proliferation or growth of the uterine lining. Now, if it's growing, at some point it will get unstable, like a tower of blocks, and will fall out. And falling out of the uterine lining is bleeding. So we do not want to have random bleeding. So if you want to be on a hormone regimen that has no bleeding, you say, I'm done, I'm in menopause, I don't want any more bleeding. How are you going to manage that? Because estradiol will create growth factors. Now, these growth factors will grow the uterine lining. That is just what happens. It's how it works. Now, if you don't want to have growth factors, then there's only one thing you can do. Don't give too much estradiol. You have to give very tiny amounts. And what else do you have to do? You have to give progesterone every single day, because progesterone downregulates the estrogen receptor, so it makes the estrogen less effective on the receptors to create less growth effect. And the progesterone basically knocks down the estrogen's potential. And I'm using estrogen and estradiol interchangeably here, but I hope that I'm talking about estradiol because we're talking about the estrogen that we're giving women in the menopause, which is estradiol. So when you give progesterone every single day, it will downregulate the estrogen receptor function every single day to reduce the effect of the growth factors on growing the uterine lining. So if you concoct, and I say concoct because this is definitely not found in nature, there is never, ever a time in a woman's life when she would naturally make a little bit of estradiol and a little bit of progesterone every single day. That never exists in nature. That's why I said concocted. So you create a hormone regimen, a menopausal hormone therapy, and that's what we call it. If you are part of the Menopause Society, I don't use their terminology. I use the old-fashioned terminology, which is still what's used mostly in Europe, which is hormone replacement therapy, because that is really what I'm doing. I'm not just giving hormones. I'm really trying to replace the hormones that are missing because of ovarian aging or senescence. Now, back to trying to prevent bleeding, because first you have to understand what the regimens are to try to prevent bleeding, so then you can understand what happens when you have unpredicted, unwanted bleeding and why that is happening, and then what to do about it. If you are trying to have this regimen where you are preventing bleeding, you're going to have a very small dose of estrogen, estradiol, every day, and then every day some progesterone. The typical dose that is used is 100 milligrams of oral micronized progesterone, but some people use other numbers. They can use compounded numbers of anything if you have it made to order, or the other branded amount is 200. And I have seen some people using 200 milligrams every day. So you're going to have typically 100, and occasionally some people would prescribe 200 milligrams of progesterone on a daily basis. Because once again, progesterone downregulates, makes less functional the estrogen's actions on its receptors. And one of the main actions of estrogen, it has so many wonderful benefits, is creating growth factors. So you want to suppress those growth factors so you don't grow the uterine lining, or very, very little, keep it suppressed, and you have to do it in this manner. Well, this is quite an art in a way, because you want to prevent having bleeding. At the same time, you want to have the woman not have the symptoms, because this regimen is typically used to prevent or reduce night sweats and hot flashes. Now, there is some evidence, depending on the dose of estradiol used and the amount that's achieved in terms of levels in the body, that you may help reduce bone loss. So there are some benefits. And by the way, getting rid of night sweats and hot flashes are good for the whole body, because you get better sleep and you have just better vasomotor function. So it's much better to have no hot flashes than to have any, or less is better than more, and less in severity is better than more severity. So there are definite huge benefits, and I don't want to belittle them, in terms of just suppressing night sweats and hot flashes with this daily static regimen. But here's the problem. Sometimes you do need to have more, and especially over time, because the receptors can all become sort of like, because then the receptors are not working well for anything, including the progesterone. And then sometimes after a year, sometimes two, on these regimens, sometimes what happens is night sweats and hot flashes can actually start to return. So then people tend to up the dose of the estradiol, and that will have an effect on the uterine lining and cause growth. Sometimes even without raising the dose, just keeping it the same, a little tiny bit of growth will happen. A little bit of growth factors are still being produced. So think of if you have a tiny drip from a faucet. It's just a tiny drip, but the drain is plugged. Over time, it may take quite a while, but eventually the sink bowl will fill with water and overflow. So even a little bit of growth over time can add up, add up, add up. And before you know it, what do you have? You have too thick and unstable a uterine lining. When your uterine lining is too thick or unstable, whoop, it can fall out. That's unplanned bleeding. No one wants unplanned bleeding. I can tell you, in the Women's Health Initiative, where they gave a combo called Prempro, it was medroxyprogesterone acetate, that's a sort of a mimic pseudo-progesterone called a progestin, combined with the conjugated equine estrogen, the brand name Premarin. Oh my goodness, so many women had what we would call irregular, unplanned, unscheduled bleeding. Some people call it breakthrough bleeding when you're talking about something similar that happens on birth control pills, where a very common side effect of birth control pills is just unplanned, unscheduled bleeding. Well, the same thing happens with these static daily combo progesterone and estradiol blends that are given either together, because there is now a pill that actually blends the two together, or given separately, often as a transdermal patch or gel, and then the oral pill. Either which way, when they're both given on a daily basis, there is a significant incidence of bleeding over time, this unscheduled bleeding, and it ends up causing a lot of problems. A lot of women end up having a lot of ultrasounds and uterine biopsies. Some of them, they throw in the towel. Their doctor says, let's put in an IUD that has levonorgestrel. One of the brand names is Mirena. And they put in these IUDs that have this progestin embedded in it to try to prevent bleeding. And then they have bleeding anyway, and then they give them progesterone as well. We have no data for that. So there's all kinds of things that happen when you try to prevent nature's natural event, which is growing the uterine lining. Now, if you grow it, and you really grow it, and you just let the estradiol do its thing and have it a more physiologic or biologically like a relatable level, then you will grow the uterine lining. And here's one of my mottos. If you grow it, you must shed it. You can't just keep growing the uterine lining. It will become, like I said before, a tower of blocks and just come out. There are many studies that seem to be forgotten. The studies are not forgotten. The regimens are forgotten that did cyclic. That means you're trying to create bleeding, or certainly permitting it, by giving pulsed progesterone. In a normal menstrual cycle, like I said, there's 2 weeks of the luteal phase or the secretory phase, depending whether you're referring to the ovarian or the uterine, reaction to the hormones. So there's 2 weeks when the progesterone is produced. And during that time, things are happening, all kinds of things. Receptors are up and down regulated, genes are turned on. It's like a whole new world that's going on when you have the progesterone, and things change when the progesterone is no longer being produced. These hormones are doing many things in the body besides just growing and shedding a uterine lining. Nothing in the body has one single purpose. That's really important to always keep in mind. So in some of the studies that were done with cyclic progesterone, they were the PEPI study, the KEEP study, the ELITE study. These are studies that are quoted, referred to, referenced all the time. And somehow people forgot that these studies used cyclic progesterone along with the estrogen component, which was on a daily basis. And when the Women's Health Initiative came out, they used that combo pill, which had become somewhat popular, but was already being phased out in many places by topical or like patch estrogen. And what was used in that study was the combination of a daily combined pill of the medroxyprogesterone acetate and the conjugated equine estrogen. And there, like I said, there was so much of this unscheduled bleeding. Many women immediately knew they were on the hormones and not the placebo, because they suddenly, for the first time in a decade or more, started having vaginal bleeding. So many women on the combined static daily regimens will have this unscheduled bleeding. And I see it all the time in my patients who come in. But in terms of the cyclic, you have what is planned bleeding. So in that case, you take the estrogen on a daily basis, and the progesterone would only be used for 2 weeks. Some studies have used, like, say, 12 days. I use 14, and many people also who do the cyclic use 14 days of the progesterone. So when you give the cyclic, it's planned that you will stop the progesterone after 2 weeks, and then the uterine lining will purge itself. You'll have shedding. That's what we actually call the period. It's the shedding phase. And that lining will come out. And it's like a beautiful rebirth. Think of it as a purge. And then you have this, like, the seasons of the uterine lining. And the seasons of the uterine lining are reflected elsewhere in the body. Because when you have the different phases, you have genes, like I mentioned, up and down regulated, receptors up and down regulated, endocannabinoid system up and down regulated. There are many things that are happening. Now, you can have unscheduled bleeding when you use the cyclic regimen as well. That is certainly possible. And why would that happen? Because we're not perfect and we're not recreating exactly, not even close to exactly, the hormones of a perfect menstrual cycle. That might be a nice goal. We're not there. We're not even close to there. So, and it's very complex. I don't think very many women would want to do it. So we're trying to do something that is going to be similar and give you a lot of the benefits without all the complexity. So you have to accept that when you do hormones, whether it's static, daily, or when you do the cyclic, where you're doing the pulsed progesterone for 2 weeks out of each cycle, that you could have some irregular bleeding because the uterine lining can grow and then can become unstable and fall out even when you're doing the best of everything. Now, one of the things I've also found is when you use the estrogen patch, the estrogen that's released from the patch, and there are many manufacturers now, and they're almost completely generic now, and they're not really identicals, they're similars. So different women will respond differently to different manufacturers. But with any of these patches, the amount of estrogen that's released, it's estradiol, is more on the first day that the patch is on compared to the second and the third and then the third half day. So the estradiol level in the blood will go up when the new patch is on and then go down, and then you put on a new patch. As the uterine lining grows in a cyclic situation, or even in a static situation, either way, if you're using the patch, the amount of estradiol is going to vary with the day of the patch. And if the uterine lining grows and the estrogen released from the patch is dropping, it can create instability of the uterine lining due to a reduced amount of estrogen. Remember, when a woman has a natural period, what triggers it is the dropping of the levels of progesterone and estrogen that no longer are there to support the health and growth and stability of the uterine lining, so it comes out. But this can happen whether you're doing static or cyclic types of pulsed progesterone regimens because of the variation in the estradiol level on the day of the patch. Now, what if you did something else? Well, even when you do something else, whether it's the gel or you do compounded, or if somebody, which I don't like, but if they did a pellet, the amount can fluctuate. You can still have variety of levels during the course of the day and from day to day because of different temperatures of the skin, how somebody applies it, the rate of absorption, all kinds of things can affect it. And you could have dips in the blood level, and that can reduce the support to the uterine lining, and then you can have some bleeding. Most bleeding that occurs on hormone replacement therapy is going to be harmless. It's just annoying. It's just instability of the uterine lining because of fluctuations in the hormones and the way that the growth factors are working on the uterine lining. And they're not a sign in most cases, they're not going to reflect, I should probably say, that there's something really bad going on in the uterine cavity, like precancer or adenocarcinoma of the endometrium, cancer of the uterine lining. But you always have to know for sure. So you have to do things to check. So the bleeding does lead to sometimes, people get a second chance, you know what's happening, you try a slight variation of the regimen. So I'm not saying everyone who has any unplanned, unscheduled bleeding immediately has to have ultrasounds and uterine biopsies or DNCs. But they all need to be followed to see if it continues, if you change the regimen, if you make it any other kind of modification. If they keep having unscheduled bleeding, then what we typically do is get a pelvic ultrasound to see how the uterine lining is looking. If it looks like there's a polyp or a submucous fibroid, a uterine leiomyoma fibroid going into the cavity, or like I said, a polyp, or if it looks like the uterine lining is extremely thickened, something like that. If you have abnormality, then you would have to do something more aggressive like a DNC. That's where you go in and you look, that's with the hysteroscopy, and you scrape out in an operating room the uterine lining, or an office endometrial biopsy, which involves just putting a very fine little plastic flexible cannula into the uterus and then sucking out uterine lining, sending it to the pathologist to confirm that there is or is not some pathological process going on. Usually what comes back on the pathology is dysfunctional proliferative endometrium, that basically that the uterine lining is all different heights and it's just coming out, and it's not cancer, it's not precancer. But every once in a while, someone will have cancer, and it's really important that nothing goes unproven. So all bleeding that's unscheduled, unplanned, and all bleeding on the continuous static method, where you're taking progesterone and estradiol every day, all of that bleeding is unscheduled. With cyclic, you have planned bleeding, and it should be like a little, very few days of bleeding that most women, when they understand the benefits, and I'm not going to go into the benefits today, but there are many benefits from having the cyclic regimen, because just as a quick, recap of what I'm going to say, and I have said before, is that growth factors, and that's just one thing that you get when you get better biological levels of the hormones in the body. Growth factors produced by estradiol not only grow the uterine lining, they create growth factors in the brain, like brain-derived neurotrophic factor, nerve growth factor. There's all kinds of transforming tissue growth factors that create new growth. There's growth factors that create new blood vessels. They restore, they make new bone. So growth factors are important for growing, repairing, remodeling, rejuvenation, maintaining. All of those things are so critical. And you need to have an adequate amount of estradiol. So I view, it's all how you frame it, I view the shedding, the bleeding, the timed, planned bleeding that you get when you do cyclic use of the progesterone, and you use better, more appropriate to biology levels of estradiol, that the bleeding is a sign things are working, that you're getting those wonderful, beautiful growth factors. But for women who just say, no way, I don't want to bleed, I'll take my chances, I want to do other things to be healthy, they need to be prepared for unscheduled bleeding, because that's the nature of the game when you put estrogen into the body and you have a uterus. So people try to come up with these regimens to prevent bleeding. They don't always work. And when you do cyclic, you want to get programmed, planned bleeding, but it doesn't always work properly because there are so many unpredictable factors, how you absorb it, the levels, how they're maintained, how your uterine lining responds, how you're doing the progesterone, more topics for another day, whether you're using the progesterone as an oral pill, a vaginal, a rectal insertion, or a topical cream. So the levels you achieve, the stability of the levels, there's a lot of factors here going into all kinds of ways that the uterine lining can become unstable and then fall out and create this unplanned, unscheduled bleeding. Remember, the vast majority of the time, it will just be disordered proliferative endometrium, not a problem except for annoyance problem. But once in a while, a woman will get precancer and cancer of the uterine cavity, and that needs to always be ruled out. We always have to go through the rule outs. So make sure if you have any abnormal or unplanned, unscheduled bleeding, that you report it to your healthcare provider. We never want to miss a cancer. Never, ever. So bleeding comes with the territory as a side effect of hormones. No matter how you give it, it's always out there lurking as a possibility. And it's just a sign the hormones are doing what they're supposed to do. Sometimes not in the way we want them to do it, though. But hang in there. Hormones are worth it.